Andy, thanks very much for coming in to do this. As you know, it's a series of interviews with people for advice for your successors, and we appreciate you don't have one. But if you were handing down a couple of key lessons from your time, what would they be?
I spent a lot of time in my career inventing and trying to implement incentives for hospitals, really financial incentives with payment by results, and perhaps even competition itself and splitting purchase and providers. And I'm a very disappointed man because actually I don't think they've had much impact on the service. And I think there's still a tendency to think that if only we could get the financial incentive right, everything would be much better. But it's clear that they won't do that. They may as part of a package. But I think we might have spent more time in my career thinking about the information that was available, that we should have been collecting about the quality of the service, and that we should have been making public, both to professionals and to the public. So I think I would now be putting more faith in information and transparency than I would.
Clinical outcomes, all those sorts of things.
Clinical outcomes, patient experience, all those things which we didn't do until relatively recently, or didn't start to do until relatively recently. And I think looking back, that's an opportunity lost. So I'd now be saying, let's put more effort into that and less into thinking about the next financial incentive.
Right, that's quite a conclusion to come to, because I mean, in a sense, you were there at the very beginning in the original devising of the purchase provider split by Ken Clarke in '91, and you had a lot to do with PVR and the other things over the years.
It is a conclusion. It is quite a surprising conclusion. I don't necessarily think that what we did was worthless, because I think it did have some benefits. And and you wouldn't
want to go and scrap them.
And I certainly wouldn't want to go and scrap them, because I think that would then be a retrograde step, because we spend a lot of time putting something else in its place and still not make much progress, I think. But maybe it's a problem of expectations, that my expectations, and perhaps those of the people who were like Ken Clarke and so on, were very much higher than they really ought to have been about the way they would work and the way in which they would be implemented. But having said that, I still think, having tried these things, I don't think they made much impact, and that's over 20 years experience. So I am a bit disappointed in that. I wouldn't scrap them, but I think we need to look more at the direct problem that we're trying to solve, rather than do it indirectly through a system of incentives. And if we think that one of the problems is variable quality, well, we need to get information about the quality and its variation and start by making that public.
Right, and it's part of that faith in the fact that if you make this public, peer pressure will have an enormous impact on performance, in that people won't want to have poor results and be seen to have poor results.
Well, I think peer pressure will have an impact. I guess I could be accused of, well, that's transparency is the fad of the 2010s, Absolutely. As financial incentives was the fad of the 1990s. So I suppose my conclusion from that is, although I say I'd put more effort into that, I don't think it's going to be the solution.
No.
And that it would come as part of perhaps as a package. So actually, where even in hospital services, perhaps financial incentives have worked a little bit, is where there's been better information about the quality of the service, agreement on what it should look like, transparency of that information, wrapped by a clear clinical consensus, guidelines, a campaign to achieve it, and a little bit of financial incentive on the top of that.
And you're right to say transparency is the current fad, so to speak, the current fashion for tackling all this stuff. But we haven't got very far with it. We've been working at it for a long time. I mean, I, like you, can recall Virginia Bottomley promising to publish outcome data on a massive scale nearly 20 years ago. And we're only just getting round to it.
Well, I think that's an indictment of the PAR system. There's a lot of promises or commitments have been made on information and the publication of information and comparable information, which just haven't materialised. So I think it was our Darcy's High Quality Care for All, which said that the National Commissioning Board would annually publish data on England's performance and compare that internationally. Well, that's never happened and seems to have no prospect of happening. And I think that's partly because we move on to the next policy. We go back into mega change in terms of reorganisation. And maybe if we'd stuck to some of those commitments about information and made that as high a priority as we made financial incentives or reorganising PCTs, we might be a lot further on.
Right. You've made the point about the disappointment of financial incentives, payment by results, those sorts of things, even best value tariffs in hospitals. Do you think the same applies to general practice? I mean, there is some evidence if you give GPs financial incentives, they respond like mad.
There's a lot of evidence that if you give GPs financial incentives, they do respond like mad, so they have worse. So I think Ken Clarke introduced some of the first in terms of cervical cytology screening, targets for cervical cytology and vaccination and immunisation, and achievement rose significantly against those. You could point to the quality and outcomes framework where performance is very high. So they do work, and the issue in for GPs, in a sense, is can you devise the right incentives and do you pay the right amount
for the right things?
For the right things. So at the same time as cervical cytology screening was working, there were payments for health education classes, which mushroomed and probably had very little value and threatened to destabilise the whole GP payment system.
Right, because
it had to be reformed.
Right, because they were being paid an awful lot for health education classes that weren't very good with no cap budget.
Yes.
So the rest of the budget was getting squeezed.
So the rest of the budget was getting squeezed.
So you have to be careful how you design
So you
these things.
absolutely have to be careful how you design it, what you're paying for, are you paying for the right things, and are they actually tackling the essential things that you want them to tackle? So, and maybe one of the issues is it's frequently said that variation in general practice is one of the weaknesses of the health service. And in a sense, quite a lot of the incentives have been geared to ironing out variation.
Yep.
But we still seem to be left with it. So maybe either we haven't got the incentives and the payment right, or there's some fundamentally different approach, alternative approach, that we need to look at.
Yeah, and publishing data will be one of the things that might well help with that.
Publishing data might be one of the things that would help with that.
Yeah, great. Andy, thank you very much.